Welcome to the IDPH Obstetric Hemorrhage Program. Each year, at least 160 million women become pregnant around the world. Of these women, 15% develop complications related to pregnancy, which leads to the deaths of about 600,000 women. Many of these deaths could have been prevented. In fact, over 10 million women suffer annually from complications that seriously affect their health, often permanently. Postpartum hemorrhage is an unpredictable and rapid cause of maternal death worldwide. Current evidence indicates that with appropriately trained staff and the necessary equipment, there can be a significant reduction in the incidence of hemorrhage. Improving healthcare for women during childbirth in order to prevent and treat hemorrhage is an essential step towards the achievement of Healthy People 2020 goals. The information provided in this program is meant to define practices that meet the needs of patients in most circumstances and are not a replacement for clinical judgment. The ultimate decision about care of a particular patient must be made by the healthcare provider and patient in light of the circumstances presented by that patient. Case number 1. This is a typical case that could have happened in any hospital in the United States. At 28 weeks, patient presents with a complete previa with profuse vaginal bleeding. On admission, blood pressure is noted to be 109/70, a heart rate of 110. Hematocrit on admission was 22% and had noted to be 30% 2 days prior. Patient is taken for immediate C-section performed under general anesthesia. EBL in the case is 750 mL. Fluid replacement provided was 2,500 mL. Urine output 200 mL. And post-extubation heart rates in the 120s. Subsequently, the patient became oliguric without improvement after several fluid boluses. Patient then became anuric and developed into DIC. Patient was then taken back to the OR with exploratory lab showing no evidence of intraperitoneal hemorrhage. Case number 1, question 1. Patient status post-op uneventful C-section for bleeding becomes anuric and is oozing from incision site. The patient is taken back to the OR for presumed intra-abdominal bleeding. Exploratory lab shows no evidence of intraperitoneal hemorrhage. The most appropriate next step in management of this patient is A. Aggressive volume replacement with blood products. B. Urology consult to assess for concealed GU injury. C. CT scan of abdomen to look for concealed bleeding, or D. Renal consult to work up her renal disease. If you chose A, you are correct. Aggressive volume replacement with blood products is indicated in managing this patient. Case number 1, identified missed opportunities for care. There was a noted delay in the diagnosis, starting with an underestimation of blood loss, particularly prior to the hospital admission, and the delay in recognizing hemorrhage and profound hypovolemia. Second thing noted was a delay in treatment. Inadequate initial resuscitation of this patient resulted in irreversible hemorrhagic shock, coagulopathy, and acute tubular necrosis. The time from this patient's admission to death was 21 hours. Worldwide, hemorrhage remains the #1 cause of maternal mortality and the most common form of shock in obstetrical practice. The high number of maternal deaths in some areas of the world reflects inequities in access to health services and highlights the gap between rich and poor. According to UNICEF, from 1990 to 2013, the global maternal mortality rate has declined by 45%. Although there has been improvement, it is not enough. There are still areas, like sub-Saharan Africa, that have extremely high rates of maternal mortality. Between 1994 and 2006, overall we see an upward trend of hemorrhage, with the major indication being uterine atony. The graph above shows percentages of pregnancy-related deaths in the United States in 2011. Please note that hemorrhage is the 4th leading cause of death at 11.3%. It is also important to note the cause of death is unknown for 5.9% of all the 2011 pregnancy-related deaths. Over the past 10 years, hemorrhage deaths have moved to the fourth leading cause of death in the United States. Many of these deaths are still preventable. The National Center for Health Statistics states indirect causes occurred at a rate of 3.1 per 100,000 and comprised deaths from pre-existing conditions complicated by pregnancy. The rate of maternal deaths from unspecified causes was 0.5 per 100,000. Other articles found the percent of obstetric hemorrhage deaths determined to be preventable. 54% and 70% had a good or strong chance of being prevented. Maternal deaths due to obstetric hemorrhage came from all levels of care throughout the entire state, including Level 3 hospitals and perinatal centers. The 3-year total from the years 2006 to 2008 was 11 deaths resulting from obstetric hemorrhage. Once the obstetric hemorrhage program was implemented in 2008, we had a decrease of 5 fewer deaths in that time period. But once again, our immediate cause of deaths from hemorrhage are currently increasing. The table on the left side of this slide is differentiating the etiologies of hemorrhage deaths, both direct and indirect, during the years 2007 to 2013. During that time period, the MMRC reviewed 36 cases related to hemorrhage. That is compared to the 20 cases that were reviewed between 2001 and 2006. It's important to note that these deaths did not include gunshots, domestic violence, or car accidents. The other category in this table notes hemorrhage deaths related to other things such as abortions, retained placental fragments, factor deficiencies, or placenta accreta. The table on the right side of this slide is there to demonstrate that the majority of maternal deaths due to blood loss were found to have been preventable factors related to patient care. Potentially avoidable provider, which includes physician, nurse midwives, and registered nurses, care factors include no or inadequate identification of risk factors, delayed diagnosis or incorrect diagnosis, unrecognized abnormal vital signs or signs and symptoms of hypovolemia, underestimation of blood loss, delayed and or inadequate treatment, under-resuscitation, inadequate volume or product replacement, inadequate or inappropriate referral, consultation, or transfer of care, inadequate documentation, or chain of communication issues. The goal of this program is recognition and prevention of morbidity and mortality from obstetric hemorrhage. The program objectives are to improve risk assessment and preparation, early recognition of obstetric blood hemorrhage, including quantification of blood loss and recognition of hypovolemia, improve treatment of hemorrhage and hypovolemia. To create and implement rapid response teams for coordinated management, policies and guidelines including rapid transfusion protocol and active management of the third stage of labor. The intervention is education. No single satisfactory definition of hemorrhage exists, and a number of definitions are currently in use worldwide. While existing definitions allow comparison of rates of hemorrhage, the clinical relevance of these volumes of blood loss in otherwise fit, healthy women is questionable. Many of the deaths in Illinois were missed because the antepartum blood loss was not calculated. For our purposes in this program and in the state of Illinois, the definition of perinatal hemorrhage is persistent, ongoing, active bleeding greater than 1,000 milliliters within the 24 hours following birth that continues despite the use of initial measures, including first-line uterotonic agents and uterine massage. Having a definition helps Illinois look at morbidities and compare data throughout the state. Having a definition that includes a specific amount is meant as a starting point in the evaluation of a hemorrhage. Determination of rates of clinically severe hemorrhage may be more useful. From this, we can determine if the severity of a hemorrhage is influenced by the rate and total volume of blood loss and also the response to treatment. This definition is more of a coding definition, but each hospital must have processes in place to be able to monitor and evaluate cases. We will also include antepartum patients who come in bleeding, have to be delivered, and continue active bleeding for 24 hours. OB hemorrhage case number 2. This is a typical case reviewed by the Maternal Mortality Review Committee. A 42-year-old, gravidas 7, para 5, at 37 weeks, with a prior IUFD, 3 prior C-sections, and a known placenta previa, presents for repeat C-section due to worsening hypertension. Her pressure range on admission is 186/92 to 198/98, heart rate 80. Initial labs, hemoglobin 14.6, hematocrit 43.8, and platelets of 190. The findings at delivery were adhesions to the omentum to the anterior abdominal wall and bladder to lower uterine segment. Complete placenta previa. A viable male infant was delivered at 1743. Intraoperative EBL was 700 milliliters and the intraoperative BP 140/88. Case number 2, question 1. This patient's history of 3 prior C-section deliveries and a known placenta previa puts her at increased risk for A. Antepartum hemorrhage, B. Placenta accreta, C. Ruptured uterus, or D. All of the above. If you selected D, you are correct. Case 2, question 2. In addition to her placenta previa, which would be considered a risk factor for perinatal hemorrhage, choose the best answer. A. Chronic hypertension, B. Grand multiparity, C. Maternal age, or D. History of an IUFD. If you chose B, you are correct. Grand multiparity is the answer because it has a direct causal relationship with obstetric hemorrhage. The other high risk factors listed may lead to hemorrhage. For example, hypertension may increase the risk of abruption with increased risk of hemorrhage, but in itself is not directly linked to hemorrhage. Case 2, question 3. What additional laboratory test or tests should you consider prior to her repeat C-section? Choose the best answer. A. Type and screen, B. 24-hour urine collection for protein and creatinine clearance, C. Uric acid, or D. Type and cross-match. If you chose D, you are correct. Deciding whether to order a type and cross or a type and hold should be based on factor risk analysis. By initially attaining a type and cross or a type and hold, time and or cost is saved over obtaining a type and screen followed by a type and cross. In this section, we're going to discuss the importance of risk assessment and preparation. The most important point to remember is that the plan is always based on the etiology of the hemorrhage. This slide is a review of the risk factors associated with hemorrhage. Although uterine atony was previously a major cause of peripartum hemorrhage, more recently it appears that abnormal placentation is the leading etiology and the main indication of peripartum hysterectomy. Other factors associated with hemorrhage include general anesthesia, history of a hemorrhage, prolonged use of oxytocin, transfusion-dependent sickle cell disease, prior uterine surgery, procedure, or C-section, chorioamnionitis, polyhydramnios, and Jehovah's Witnesses have an increased risk of hemorrhage because they may not accept blood products. This is an example of an antepartum checklist that could be incorporated into a plan of care or standing orders to assess patients' risk factors associated with hemorrhage. Women with a history of hemorrhage are 3 times more likely to have a repeat occurrence, so it is important to note that in their medical record. Placental abnormalities, such as placenta previa, accreta, etc., require more in-depth assessment using ultrasound or MRI. Transfusion-dependent sickle cell means there may be difficulty in cross-matching type-specific blood. Patients with a previous uterine surgery or procedure, such as history of a D&C, having multiple abortions, or a scarred uterus, places the patient at a higher risk for uterine rupture, accreta, and adhesions, which can lead to increased bleeding. A patient of Jehovah's Witness faith needs to have a discussion between them and their provider detailing the products, if any, that are acceptable for transfusion in the event they are necessary. Patients of grand multiplicity need to have uterotonics at the bedside, and active management of the third stage of labor should be continued. Staff at each facility must review the options available for managing a hemorrhage. Discussion should include options which are not frequently used or not readily available, such as using a cell saver or interventional radiology, the location of your lab and blood bank available to your unit. For scheduled cases, it may also be appropriate to consider whether or not this case should be performed in the main OR versus the L&D OR, should be the first case of the day, the last case of the day, additional staffing requirements, and the time of day it's to be performed. Case number 2, question number 4. At what point do you first suspect potential hypovolemia? A. 1815 with a blood pressure of 117/69 and a heart rate of 108. B. 1855, a blood pressure of 98/61, a heart rate of 110. C. 1903, blood pressure over 99/56 and a heart rate of 118. Or D. 1920, blood pressure of 90/50 and a heart rate of 120. If you chose A, you are correct. It's important to remember that this is a 42-year-old gravidas 7 para 5 at 37 weeks of a prior IUFD, 3 prior C-sections, and a known placenta previa who presents for repeat C-section due to worsening chronic hypertension. Her heart rate increases from admission of 80, intraoperative of 90, and to the recovery room of 108. This is an upward trend. Her blood pressure of 117/69 from a blood pressure on admission of 186/92 and intraoperatively of 140/80 shows a downward trend. The first set of vital signs in the recovery room shows a significant change when compared to the admission and intraoperative vital signs. Always remember to be suspicious if a blood pressure in a hypertensive woman becomes normal. Recognition, visualization, and quantification of blood loss. The blood loss at a vaginal delivery is given as 350 milliliters. To quantify this amount correctly, the blood volume in the collection drape would fill A, standard soda can, B, half gallon of milk, C, pint of milk, or D, quart of milk. If you chose A, you are correct. 350 milliliters would fill a standard soda can. The only accurate method to quantify blood loss is weighing it. In an emergency situation, when no other help is available, comparison to familiar objects may be helpful. After the emergency is over, weigh the item saturated with blood. Remember, 1 gram is equal to 1 milliliter. Case number 2. 3 hours postpartum in the recovery room. The patient passes 3 orange-sized clots and receives a 500 milliliter fluid bolus. Post-infusion, the blood pressure is 108/70 with a heart rate over 115. Question 5. The first fluid bolus ordered at this time was 500 milliliters. This amount is A. Adequate, B. Adequate if vitals checked Q5 minutes and bleeding slows, C. Adequate if blood replacement is ordered, or D. Inadequate. If you chose D, you're correct. Fluid replacement should follow the guidelines of 3 milliliters of replacement to 1 ml of blood loss. Visual estimation is not a reliable predictor of blood loss and should only be used if there is not enough staff during emergent situations. Each hospital is encouraged to chart the weight of individual disposable underpads, laps, etc. Knowing the dry weights of items and then subtracting the dry weight from the soiled weight will give the most accurate method of calculation. NICU units have successfully used this system for years. A standard 18-inch by 18-inch lap that is 75% saturated with blood represents a blood loss of A. 25 milliliters, B. 50 milliliters, C. 75 milliliters, or D. 100 milliliters. If you chose B, you are correct. It is imperative the blood loss be assessed and measured as accurately as possible. Knowing the dry weights of items and then subtracting the dry weight from the soiled weight will give the most accurate method of calculation. Remember, 1 gram of blood is equal to 1 milliliter. In this slide, you will see some examples of quantification of blood loss. For example, the soiled weight of a pad is 100 grams. The dry weight of a pad is 15 grams. So 100 minus 15 equals 85 grams, which equals 85 milliliters of blood loss. Quantification of blood loss is the state of Illinois standard. Visual estimation has been reported to be less accurate than quantification of blood loss. Individuals tend to either overestimate or underestimate. Overestimation can lead to costly interventions which can include administration of medication and blood products that may not be needed. Underestimation, which is the most common error, can lead to delayed treatment, increased morbidities, and mortalities. IDPH is requesting weighing or measuring contents for accuracy. The addition of calibrations to vaginal delivery drapes can improve the accuracy of EBL to an extent similar to other quantifying methods such as photospectrometry without the added costs or limitations. Quantification of blood loss is the state of Illinois standard. This is an example of an Excel spreadsheet that can be structured to auto-calculate the quantified blood loss. An insidious feature of hemorrhage is the failure of the pulse and blood pressure to undergo more than moderate alterations until large amounts of blood have been lost. The maternal response to blood loss depends on the magnitude of pregnancy, induced hypervolemia, the amount of volume lost, and internal adaptive mechanisms. It's important to note the normotensive woman may actually become somewhat hypertensive in response to hemorrhage, at least initially. A hypertensive woman with blood loss may become normotensive because she is hypovolemic with a greater than 1800 milliliter blood loss. Ultimately, the hypovolemia may not be recognized until very late. When it comes to fluid replacement, the maximum volume of infused clear fluid should ideally not exceed a total of 3.5 liters. Up to 2 liters of warmed crystalloid solution as rapidly as possible, followed by up to an additional 1.5 liters if blood is not available while awaiting compatible blood. Causes of obstetric hemorrhage associated with an intrauterine gestation include placental abruption or previa, uterine rupture, surgical laceration, invasive placentation, or uterine inversion. The causes of postpartum hemorrhage can be classified into 4 main groups. Uterine atony, which is a major cause of postpartum hemorrhage, accounting for up to 80% of cases of primary postpartum hemorrhage. Placental, including premature separation of the placenta or abruption. Retained placenta and abnormal placental implantation, such as a previa, which can occur during antepartum, intrapartum, or postpartum periods. Genital tract trauma, which can occur during intrapartum or postpartum period. Systemic medical disorders, including inherited and acquired coagulation defects, which can occur during antepartum, intrapartum, or postpartum periods. Remember that 2 processes often occur simultaneously: hemorrhage and hypovolemia. Remember, at all times blood loss may be concealed or may have occurred prior to admission. It is important to identify signs and symptoms of hypovolemia in addition to measuring blood loss. Choose the earliest sign of compensatory change that occurs with hypovolemia. A. Tachycardia. B. Hypotension. C. Hyperventilation. Or D. Pallor. If you chose A, you are correct. Tachycardia. Initially, providers use visual estimation when evaluating blood loss. However, following vital sign trends is imperative for the recognition of hypovolemia. The question to ask is, does the visual estimation of blood loss correlate with the vital signs? As soon as possible, weighing should be implemented. With hemorrhage, vital signs and patient status will usually change in the following order. 1. Pulse is the first to change. 2. Respirations. 3. Pallor. 4. Mental status. 5. Urinary output. 6. Delay in capillary refill. And 7. Blood pressure. This is the last vital sign to change. The physiology of blood loss would be 30% blood loss would be equal to 1,500 to 2,000 milliliters. The pulse rate increases after about 15 to 20% of blood volume has been lost. Tachypnea is an early sign, partially driven initially by anxiety. As the respiratory rate increases with progressive blood loss, respirations will usually exceed 20 breaths per minute when 30% of blood volume is lost. Pallor. Oxygenation becomes harder to assess clinically as peripheral pallor becomes more marked, and the pulse oximeter becomes less reliable as peripheral perfusion becomes weaker. Change in mental status. Early stages of shock are associated with restlessness and agitation, sometimes with a heightened sense of thirst, but these progress to drowsiness when around 30% of blood volume is lost. Loss of consciousness is a very late sign with significant risk of imminent death. Capillary refill is slowed after 15% of blood volume is lost and is also completely absent when 40% of volume is lost. In cases of severe hemorrhage, the minimum rate of urine output per hour needed to prevent renal tubular necrosis is A. 10 milliliters an hour, B. 30 milliliters an hour, C. 100 milliliters an hour, or D. 300 milliliters an hour. If you chose B, you are correct. In cases of hypovolemia, blood is shunted away from the kidneys, increasing the risk for tubular necrosis. Hypovolemia is a clinical condition characterized by inadequate tissue perfusion from impaired peripheral circulation because of diminished intravascular blood volume. A 130-pound pregnant woman has a blood volume of 6,000 milliliters at 30 weeks gestation of pregnancy. A 1,000 milliliter blood loss results in vasoconstriction of venous and arterial vessels to maintain perfusion of essential organs, increase in systemic vascular resistance to maintain blood pressure until blood loss exceeds 30%. After a 30% blood loss, the blood pressure and cardiac output fall in parallel. Because of the increase in circulatory volume and increased SVR during pregnancy, changes in the vital signs are delayed. Blood pressure is the last vital sign to change and is due to systemic vascular resistance and cardiac output. There are decreases in mean arterial pressure, stroke volume, cardiac output, central venous pressure, and pulmonary capillary wedge pressure. There are increases in oxygen content, although overall oxygen consumption falls. In addition, there is a redistribution of cardiac output and blood volume by selective, centrally mediated arterial constriction. This results in diminished perfusion to the kidneys, splenic beds, skin, and uterus, with relative maintenance of blood flow to the heart, brain, adrenal glands, and organs that auto-regulate their own flow. Obstetric case number 2, outcome. 4 hours postpartum, the patient's urine output is 20 milliliters an hour, is receiving 1 liter of D5-LR given over 2 hours, and hemoglobin is ordered with a result of 5.9 milligrams reported back. 12 hours postpartum, the first unit of packed red blood cells is started. Blood pressure is 90/50 with a pulse of 28. Patient is combative. Blood is oozing from the IV site. Upon pelvic exam, 2 clots are removed. An additional estimated blood loss of 1,600 milliliters, and the patient coded 5 minutes after the pelvic exam. At this point, the patient has an increased heart rate, changes in mental status, and a decrease in blood pressure. Despite resuscitation attempts, this patient expired. For this case, the Maternal Mortality Review Committee identified these issues as contributing to the death of this patient. No or inadequate identification of risk factors. Patient's fourth C-section, placenta previa, and a high purity. The delayed or wrong diagnosis, unrecognized abnormal vital signs or signs and symptoms of hypovolemia, and inadequate assessment of vitals and physical findings. Underestimation of blood loss in the OR and postpartum. Patient had a pre-op hemoglobin of 14.6 and a post-op hemoglobin of 5.9, as well as delayed and inadequate treatment. Inadequate volume replacement. The first unit of packed red blood cells was started 14 hours after the C-section was performed. In this case, lack of documentation has been identified as a major problem. Documentation is key, identified as one of the big problems in cases that have been reviewed by the MMRC. Lack of documentation places both the patient and staff at risk. This slide summarizes key requirements for documentation. Each hospital will need to show evidence that the staff is aware and complies with the essential components of documentation. It is important for hospitals to assess current documentation practices as related to hemorrhage, and then reassess the quality of documentation during a huddle or debrief. The following components should be included: the date and time for each entry, names of providers and staff caring for the patient, ongoing vital sign assessment, signs of blood loss and or hypovolemia. IDPH recommends the quantification of actual blood loss for all deliveries, interventions performed, and the patient's response. Treatment and product replacement. This slide shows us that blood loss can occur at any time in the perinatal period. It also highlights that two processes are going on simultaneously. It can be concealed or overt, and interventions must be directed at correcting the hypovolemia while simultaneously treating the etiology for the hemorrhage. Once the blood loss is recognized, the underlying cause of the bleeding and the hypovolemia must both be treated. Communicate, resuscitate, monitor, investigate, and stop the bleeding. Once a significant hemorrhage has been identified, it is imperative to activate a chain of actions to assess the situation and to treat the bleeding and the hypovolemia. The first step is communicate. Get help. It's not feasible to do all the necessary actions alone. The situation may require another provider or the rapid response team. Depending on the magnitude of the hemorrhage and makeup of the rapid response team, other members may be called, such as physicians or charge nurses, anesthesia, blood bank, the nursery, or the NICU. Other simultaneous steps that should be happening are to identify the source of bleeding and abate it, or to resuscitate the patient. We want to ensure IV access with 2 large bore catheters. Draw and check labs and replace lost volume with either crystalloid, colloid, and or blood volume. Head down tilt, oxygen by mask, draw labs, and transfuse the patient. Do not wait for lab results to replace volume if hemorrhage or hypovolemia is evident. Identify ways to stop the bleeding through medications, non-surgical methods, or surgical methods. And continue to monitor your patient, trending vital signs, monitoring bleeding, and monitoring labs. Remember order for action. The acronym ORDER is used in ACOG's technical bulletin to help providers remember the actions in a logical manner. In this slide, the D, which stands for drug therapy, is most appropriate for postpartum hemorrhage. After a normal spontaneous vaginal delivery, bright red bleeding continues in the presence of a firmly contracted uterus. This is likely the result of A. Uterine rupture, B. Retained placenta, C. Vaginal laceration, or D. Thrombocytopenia. If you chose C, you are correct. The bright red bleeding is likely a result of a vaginal laceration. Uterine atony is the most common cause of primary postpartum hemorrhage. Active management of the third stage of labor consists of interventions designed to speed the delivery of the placenta by increasing uterine contractions and to prevent postpartum hemorrhage by averting uterine atony. Please note, this technique is used for prevention of hemorrhage, not treatment. The IDPH recommends the use of active management of the third stage of labor to help prevent hemorrhage. This slide discusses how active management of the third stage of labor prevents postpartum hemorrhage. Administration of uterotonic stimulates uterine contractions that A. facilitate separation of the placenta from the uterine wall, resulting in rapid delivery of the placenta, and B. compress maternal blood vessels at the placental site after delivery of the placenta. It also directs us to do controlled cord traction, which facilitates rapid delivery of the placenta and emptying of the uterus, as well as uterine massage, which stimulates uterine contractions and removes clots that may inhibit uterine contractions. The American College of Obstetricians and Gynecologists, along with other experts, recommend the administration of uterotonic agents during the third stage of labor and immediate postpartum period to prevent uterine atony and accompanying hemorrhage. Unfortunately, oxytocin can be associated with serious side effects, including tachycardia, hypotension, myocardial ischemia, and even death, especially in hypovolemic or other hemodynamically compromised women. Many of these adverse effects follow dose-response kinetics. The dose of oxytocin required to produce uterine contractions postpartum is much lower than previously thought. In addition, bolus dosing of oxytocin followed by infusion is not more effective than intravenous infusion alone and is no longer recommended. IDPH recommends using a standardized protocol for the third stage of labor management. The dose of oxytocin required to produce uterine contractions postpartum is much lower than previously thought. In addition, bolus dosing of oxytocin followed by infusion is not more effective than intravenous infusion alone and is no longer recommended. Based on the increased awareness of the dangers of administration of high-dose oxytocin and those dose-response data, experts have advised practitioners to devise rational, evidence-based protocols governing the use of oxytocin during the third stage of labor and postpartum period. A standard, premixed concentration of oxytocin should be used via an infusion pump. Administer the standardized rate immediately after the delivery of the fetus. If the patient has undergone an induction or augmentation of labor with oxytocin, the same infusion can be used for the third stage management. A first hour rate of 300 milliliters equals 18 units of oxytocin. A second hour rate of 60 milliliters an hour is a 3.6 unit. Continue this rate until the fundus is firm or the patient is transferred to the postpartum unit. A minimum of 2 hours. If uterine atony is present, the rate can be increased to 600 milliliters for 1 hour. After an hour and bleeding subsides, the rate can be decreased to a rate of 60 milliliters per hour. If the patient does not have an IV, administer 10 units of oxytocin IM, start an IV and run oxytocin at a rate of 60 milliliters an hour until the fundus is firm or patient is transferred to postpartum. Please remember, the infusion cannot be increased above 600 milliliters an hour. Consider other uterotonic agents or interventions if uterine atony persists. Risk factors for hemorrhage include, but are not limited to, cardiac disease, multiple gestations, a prolonged second stage of labor, preeclampsia, retained placenta, and obesity. Uterotonics should be used sequentially. Do not administer all uterotonics at the same time. Start with oxytocin and then add additional meds if needed. Be familiar with each of the drugs, their response time, and contraindications to use. Utilize a computerized infusion pump. The immediate value of smart pumps comes from both the reduction in programming steps required to initiate an IV infusion and the alerts that help to prevent inadvertent infusion administration errors. These pumps allow bolus and intermittent infusions to be protected with both total dose and minimum infusion time safeguards. Always use caution when administering oxytocin and documenting said administration. Each time you administer a medication, you need to be sure to have number 1, the right individual, 2, the right medication, 3, the right dose, 4, the right time, 5, the right route, 6, the right documentation. It is easier to document oxytocin dose when using a 1-to-1 concentration. You want to be sure to empty the bladder to help maintain uterine tone. The structural closeness of the uterus and the bladder means that a full bladder can interfere with uterine involution during the 3rd and 4th stages of labor. Uterine massage should be used to control bleeding from the area left denuded when the placenta separated. With uterine massage, muscle fibers contract firmly around maternal blood vessels at the area where the placenta was attached, which helps result in hemostasis. Maintain IV access. A HEP lock will allow you to have immediate access for fluid resuscitation and medication administration because it is often very difficult to gain such access in a shocked and hemodynamically unstable patient. In addition, it may take time to assemble appropriate personnel to place the lines. Assess for signs of hypovolemia and shock. Remember that 2 processes often occur simultaneously: hemorrhage and hypovolemia. Remember, at all times, blood loss may be concealed or may have occurred prior to admission. It is important to identify signs and symptoms of hypovolemia in addition to qualifying blood loss. Hematomas may be vulvar, involving branches of the pudendal artery, vaginal, especially in the area of the ischial spines, or subperitoneal. These are the most rare but the most dangerous because of the large amount of blood loss that can occur without clinical symptoms until the woman becomes hemodynamically unstable. Subperitoneal hematomas involve the uterine artery branches or vessels in the broad ligaments. The soft tissue in the areas offers little resistance, and the hematoma containing 200 to 500 milliliters can develop rapidly. Small hematomas, defined as less than 3 centimeters, are left to resolve on their own. Ice packs may be applied. Large hematomas greater than 3 centimeters may require evacuation of the blood and ligation of the bleeding vessel. Analgesics and broad-spectrum antibiotics may be ordered due to increased risk of infection. Help to relieve pain by applying ice pack, medicate with mild analgesics, position patient for comfort to decrease pressure on the affected area, catheterize if unable to void, and utilizing sitz baths. Uterinatony is diagnosed clinically by rapid uterine bleeding associated with a lack of myometrial tone and the absence of other etiologies for hemorrhage. If bleeding persists despite treatment with uterotonic drugs and other conservative interventions, surgical intervention should be used without further delay. Fundal massage can be used to assess the uterine fundus for tone and position. Uterine massage is indicated if the uterus is not firmly contracted. Support the lower uterine segment during massage to prevent uterine prolapse or inversion. Bimanual uterine compression can be used to provide effective massage. The uterus should be compressed between the external, fundally placed hand and the internal, intravaginal hand. Care must be taken to avoid aggressive massage that can injure the large vessels of the broad ligament. To be effective, it should be maintained for 8 to 10 minutes till the blood clots in the uterine vessels. This procedure is painful to women and is only undertaken in cases where drug therapy has failed. Uterotonics such as oxytocin, Methergin, Hemabate, or Cytotec can be used for bleeding that is unresponsive. Bleeding that is unresponsive to oxytocin may be due to unrecognized genital tract lacerations, including in some cases uterine rupture. If bleeding persists, additional management should be initiated immediately. Uterine tamponade may be used by insertion of a balloon that descends in the uterine cavity and occupies the entire space. thereby creating an intrauterine pressure that is greater than the systemic arterial pressure. In the absence of lacerations, the blood flow into the uterus should stop the moment the pressure in the tamponade balloon is greater than that of the systemic arterial pressure. For example, use of the Bakri balloon. When using this device, make sure to keep in mind to examine the area for lacerations in a well-lit room. That lack of vaginal bleeding does not necessarily mean that the bleeding is controlled. Hemorrhage may continue intra-abdominally through a laceration and be obscured by the balloon. Close attention to vital signs is critical. Uterine atony and lower segment bleeding from a poorly contracted placental implantation site are the most recognized indications for an intrauterine device. Uterine packing may also be used. Insertion of a uterine pack consisting of a gauze roll that is tightly packed into the uterus in such a manner that pressure is applied directly on capillary venous bleeding vessels or surface oozing from within the uterus, thereby resulting in either a significant reduction or stoppage of uterine bleeding. Another option is recombinant activated factor 7. This binds to and activates factor 10 on platelet surfaces. You must have an adequate platelet count for the patient. The disadvantage is that this is very expensive. One 2.4 milligram vial is approximately $2,500, with the typical cost of dosing greater than $5,000. Use of this medication has been shown to have a high risk of increasing the risk of thromboembolism formation. So consider physical measures for thromboprophylaxis. Uterine atony is diagnosed clinically by rapid uterine bleeding associated with a lack of myometrial tone and the absence of other etiologies for hemorrhage. If bleeding persists, despite treatment with uterotonic drugs and other conservative interventions, surgical intervention should be used without further delay. Fundal massage allows us to assess the uterine fundus for tone and position. Uterine massage is indicated if the uterus is not firmly contracted. Support the lower uterine segment during massage to prevent uterine prolapse or inversion. Bimanual uterine compression is a procedure that is painful to women and is only undertaken in cases where drug therapy has failed. To provide effective massage, the uterus should be compressed between the external fundally placed hand and the internal intravaginal hand. Care must be taken to avoid aggressive massage that can injure the large vessels of the broad ligament. To be effective, maintain pressure for 8 to 10 minutes till the blood clots in the uterine vessels. The use of uterotonics may be indicated to help control bleeding. Uterotonics such as Pitocin, Methergin, Hemabate, and Cytotec may be used. Bleeding that is unresponsive to oxytocin may be due to unrecognized genital tract lacerations, including in some cases uterine rupture. If bleeding persists, additional management should be initiated immediately. Tamponade devices such as the Bakri tamponade balloon are useful in several situations as a temporary measure while awaiting surgical intervention or arterial embolism. By insertion of a balloon that descends in the uterine cavity and occupies the entire space, thereby creating an intrauterine pressure that is greater than the systemic arterial pressure. In the absence of lacerations, the blood flow into the uterus should stop the moment the pressure in the tamponade balloon is greater than that of the systemic arterial pressure. When using this device, keep in mind that it is good to examine the area for lacerations. Make sure your room is well lit while doing so. Lack of vaginal bleeding does not necessarily mean that the bleeding is controlled. Hemorrhage may continue intra-abdominally through a laceration and be obscured by the balloon. Close attention to vital signs is critical. Uterine atony and lower segment bleeding from a poorly contracted placental implantation site are the most recognized indications for an intrauterine balloon. Insertion of a uterine pack that consists of a gauze roll that is tightly packed into the uterus in such a manner that pressure is applied directly on capillary venous bleeding vessels or surface oozing from within the uterus, thereby resulting in either a significant reduction or stoppage of uterine bleeding. Recombinant activated factor 7 acts by binding to and activating factor 10 on the platelet surface. the patient must have an adequate platelet count. However, this therapy is very expensive, as typical dosing costs greater than $5,000. Factor VII has also been associated with having a high risk of increasing the risk of thromboembolism formation. These measures are appropriate if a chance of hemorrhage is suspected prior to delivery. Acute normovolemic hemodilution. This may be undertaken in the operative room before starting cases presumed to be at high risk of bleeding. A central line is placed and blood is collected from the patient into citrated bags from the blood bank. Patients should have a hemoglobin level above 10 and no history of cardiovascular disease. On average, 500 to 1,000 milliliters of whole blood may be collected and concurrently replaced with either colloid at a 1-to-1 ratio or crystalloid at a 3-to-1 ratio to maintain hemodynamic stability. During surgery, any blood loss will have a lower red cell content. Once surgical bleeding is controlled, the patient is given back the blood previously collected. The collected blood may be stored at room temperature for up to 6 hours. This technique is acceptable to some Jehovah's Witnesses as long as the collection bag remains connected to the central venous line at all times. Overall, there is minimal evidence to suggest that ANH alone has a significant effect on the need for allogenic blood. Occasionally, patients at risk for severe hemorrhage may benefit from preoperative autologous blood donation. Patients donate units of their own blood during pregnancy, and such products will be stored in the blood bank for use on the day of surgery. Theoretically, the hemoglobin will recover between donations. In practice, however, the anemia is a limiting factor, and patients usually donate only a limited number of units throughout pregnancy. This technique is not cost-effective and is recommended only for patients with rare blood types and/or alloimmunizations to rare antibodies for whom immediate availability of allogenic blood products may be limited. When using a cell saver, blood is aspirated from the surgical field and filtered into a collecting reservoir. Filters in the device will remove molecules like tissue factor, alpha-fetoprotein, and platelets. After filtration, packed red cells concentrated to a hematocrit of 55 to 80% are obtained and can be re-administered to the patient. Tranexamic acid, or TXA, is an anti-fibrinolytic agent that inhibits clot breakdown by blocking the lysine binding sites on plasminogen molecules. TXA is not a new drug and has been used for many years to treat menageria and dental extraction in people with hemophilia. More recently, it has been used to reduce bleeding in elective surgical patients. Although there are many ongoing trials of TXA in elective surgery, the accumulated evidence already shows that TXA reduces bleeding. The use of TXA is advised in cases of refractory atonic bleeding or persistent trauma-related bleeding. These medications are considered the first line of treatment for hemorrhage. Oxytocin may be given IV, 10 to 40 units in 500 to 1,000 milliliters of crystalloid solution, IM or IU in a dose of 10 to 20 units, causing rhythmic uterine contractions that help to prevent or reverse hemorrhage caused by uterine atony. Side effects include nausea and vomiting. Methergin may be administered IM or PO. The IM dose is 0.2 milligrams every 2 to 4 hours for a maximum of 5 doses. Methergin may be given PO, 0.2 milligrams, every 6 to 12 hours, and this treatment may be continued for up to a week, causing rhythmic uterine contractions that help to prevent or reverse hemorrhage caused by uterine atony. Side effects include nausea and vomiting. Use of this medication is contraindicated in patients with hypertensive disorders or are currently displaying signs and symptoms of hypertension. Hemabate may be given IM or IU in a 250 microgram dose every 15 to 90 minutes. Do not exceed more than 8 doses in 24 hours. Causing control of refractory cases of postpartum hemorrhage caused by uterine atony. Hemabate is generally used after failed attempts at control of hemorrhage with oxytocin. Do not give Hemabate to patients with a history of asthma. Cytotec may be given sublingually, PO, or per rectum. The per rectum dose is 400 to 1000 microgram. It has been shown to be a potent uterotonic agent selectively binding to prostanoid receptors. Side effects include nausea, vomiting, diarrhea, shivering, fever, and transient headache. Thromboelastography is a method of testing the efficiency of blood coagulation. More common tests of blood coagulation include prothrombin time and partial thromboplastin time, which measure coagulation factor function, but TEG also can assess platelet function, clot strength, and fibrinolysis, which these other tests cannot. It is important to assess a woman's stance toward blood products well in advance of labor or planned surgery. After personal discussion, some women may be willing to accept some blood products, such as fresh frozen plasma, erythropoietin, cell saver reinfusion, and even some will accept red cells in the face of death. The goal during this discussion is to 1. Find common ground to manage the birth as safely as possible, 2. Build trust, or if not possible, to transfer to a program amenable with the plans, and 3. Develop a well-thought-out delivery plan to minimize blood loss and maximize decisive decisions. General principles of bloodless medicine management include to employ a multidisciplinary team approach to blood conservation, formulate a plan of care for avoiding and controlling blood loss, consult promptly with senior specialists experienced in blood conservation, promptly investigate and treat anemia, decisive intervention including surgery, be prepared to modify routine practice when appropriate, restrict blood drawing for laboratory tests, decrease or avoid the use of anticoagulants and antiplatelet agents, stimulate erythropoiesis, and transfer a stabilized patient, if necessary, to a major center before the patient's condition deteriorates. Jehovah's Witnesses follows most basic tenets of the Christian faith overall, with a few unique perspectives. One that directly impacts the care of women in childbirth is the prohibition against receiving blood. Both the Old Testament and the New Testament speak against receiving blood. For Jehovah's Witnesses, this extends to taking blood products into one's body through the veins. According to practicing Jehovah's Witnesses, it is believed that when they give their life without violating God's law, they shall be rewarded with eternal life. Violating this preconcept is said to lead to excommunication and damnation. This includes products such as whole blood, red blood cells, white blood cells, plasma, and platelets. But sometimes patients feel they can make a decision on accepting fractions of red cells, white cells, plasma, and/or platelets. Which of the following techniques may be attempted to stop uterine bleeding from the implantation site of a placenta previa during cesarean delivery? A. Bilateral internal iliac artery embolization. B. Bilateral intrauterine artery ligation. C. Intraoperative uterine packing. Or D. All of the above. If you have selected D, you are correct. The interventions on this slide may not be appropriate in all settings. The decision to use surgical interventions should be made jointly by the rapid response team and obstetrics, taking the underlying cause of the bleeding and the patient's current condition into consideration. While nursing staff will not make management decisions, it is important for nurses to be aware of the surgical options and the sequence in which they are most often performed. During uterine curettage, tissue is removed from the uterine lining. The B-Lynch suture aims to exert continuous vertical compression on the uterine vascular and muscular system. Laparotomy, uterine exteriorization, and an opened uterine cavity are always necessary. Uterine artery ligation or internal iliac artery ligation may be used as a prophylactic or therapeutic operation. There is a need for a competent obstetrician who is competent at pelvic gynecological procedures. Uterine artery embolization requires that a patient must be sufficiently stable to transport to interventional radiology suite. Embolization should be considered early because it may take time to mobilize services. When embolization is successful, the patient can rapidly recover without undergoing additional surgery. Embolization not only saves the life of the patient, but also the uterus and adnexal organs, thus preserving fertility. Hysterectomy is the best immediate option to save the hemorrhaging woman's life when uterine atony is unresponsive to uterotonics, where facilities for embolization are not available and/or the obstetrician is not well versed with the technical aspects of conservative surgical procedures or iliac artery ligation, or when the placenta accreta or procreta is present. Internal hemostatic products can be used during a cesarean section. There are 4 categories of internal hemostatic products: mechanical hemostats, fibrin sealants, flowable hemostats, and active hemostats. In a study using TXA to treat postpartum hemorrhage, the following facts are true. There were 144 women in the study, 72 in the group that received TXA and 72 in the control group. The EBL in the TXA group was 173 milliliters less than the control group. In the TXA group, the bleeding duration was shorter, and progression to severe postpartum hemorrhage and packed red blood cell transfusion was less frequent, leading to the conclusion that high-dose TXA can reduce EBL and mortality and morbidity in PPH. This is the protocol used in the study referenced in the slide before. This protocol is to run over 6 hours if needed. It's important to note that if at any time there is uncontrollable bleeding, early rescue resources should be initiated. The T1 level, TXA was given IV bolus, 4 grams, and a maintenance dose of 1 gram an hour was given for 6 hours. In the T2 level, 30 minutes into the hemorrhage, coagulation labs are drawn and current blood volume is calculated. If blood flow is greater than 50 milliliters in 10 minutes, sulpostone 500 is given over 60 minutes. In the T3 level, 2 hours into the hemorrhage, coagulation labs are drawn and current blood volume is calculated. If blood flow is greater than 100 milliliters in 20 minutes, use fresh frozen plasma, procoagulant drugs, or surgical intervention. And in T4 level, 6 hours into the hemorrhage, coagulation labs are drawn and current blood volume is calculated. TXA infusion is complete. Roles and responsibilities of staff members during an emergency will be determined by each facility. Please know your role in the hospital's rapid response team specific to caring for the OB patient. And note it is especially important to achieve the placement of a second IV line during these cares. The acronym ORDER is used in ACOG's Technical Bulletin 235 to help providers remember the actions in a logical manner. In this slide, the D is most appropriate for postpartum hemorrhage. Please remember to call for help. Oxygenate your patient with a non-rebreather mask. Restore circulation. Non-pneumatic anti-shock garment may be used. Coagulation status should be assessed and repeated every 45 to 60 minutes until bleeding is controlled and/or abnormalities corrected. Drug therapy utilizing Pitocin, Methergin, Hemabate, and/or Cytotec is appropriate. Evaluation status. Vital signs and oxygen saturation noted every 5 minutes. Record cumulative blood loss. Insert a Foley catheter. And to avoid hypothermia, use a bear hugger, warm fluids, and warm blankets whenever possible. Remedy. If fundal massage and uterotonics are ineffective, you need to consider placement of intrauterine balloon, interventional radiology, surgical interventions, or another etiology of bleeding. In May of 2007, each hospital in Illinois completed a hemorrhage preparedness assessment which evaluated the following internal resources: the availability and stat response time to obtain results of lab tests, the availability and response time from order to transfusion of blood products, and the availability and response time of personnel. The two goals of the rapid response team are to treat hypovolemia and determine and treat the etiology of the hemorrhage. The structure of each team will be different based on hospital resources, lab response time, skill, expertise, and availability of personnel. Some teams are composed of a senior nurse, a respiratory therapist, and sometimes a physician. Standing medical orders and evidence-based protocols guide the RRT's interventions and are helpful until communication with the patient's primary physician is established. Specially trained RRT staff should be available in the hospital 24 hours a day, 7 days a week, to assess and intervene with acute care patients. The lethal triad is recognized as playing a major role in the morbidity and mortality of severely injured or bleeding patients. Components of this triad consist of hypothermia, acidosis, and coagulopathy. These algorithms address how to manage the lethal triad. This flowchart summary depicts which intervention should be used at what state of blood loss. Please remember, this does not take into account for bleeding prior to delivery. This flowchart adds more information on how to correct a coagulopathy during a hemorrhage. Coagulation disorders resulting from placental abruption, amniotic fluid embolism, and consumption dilution coagulopathy are common causes of coagulopathy during a hemorrhage. This slide summarizes 4 points. 1. Maternal physiologic responses per volume of blood loss. 2. Labs to evaluate maternal status. 3. Blood replacement products in the order they are usually used, or institute massive transfusion policy, and 4. Interventions which can be used to abate the blood loss. Remember these steps. Control the hemorrhage, use best possible resuscitation products, prevent hypothermia, and prevent hemodilution. A unit of packed red blood cells contains the same volume of erythrocytes as whole blood and raises the hematocrit by 3 to 5%. Packed red blood cells and crystalloid infusion are the mainstays of transfusion therapy for most cases of obstetric hemorrhage. In platelets, 1 pack equals 6 units of platelet concentrates of a single donor and will raise the count by 500 to 8,000. Fresh frozen plasma is prepared by separating plasma from whole blood and then refreezing it. Approximately 30 minutes are required for the frozen plasma to thaw. As the source of all stable and labile clotting factors, including fibrinogen, it is often used in the acute treatment of women with consumptive or dilutional coagulopathy. FFP is not appropriate for use as a volume expander in the absence of specific clotting or factor deficiency. However, it should be considered in a bleeding woman with a fibrinogen level below 125 milligrams per deciliter, or with abnormal prothrombin and partial thromboplastin times. Cryoprecipitate. 1 bag contains 250 to 350 milligrams of fibrinogen. 6 bags, or 1 pool, contains 1,500 to 2,100 milligrams of fibrinogen. 1 unit of cryoprecipitate and 1 unit of FFP will have a similar effect on the fibrinogen level. Please note, with acute blood loss, the hematocrit will not change significantly for up to 4 hours. Remember that the infusion of IV fluids can cause the hematocrit to drop before 4 hours. A hematocrit should be obtained if a hemorrhage is suspected. If a significant drop is seen, assume a large amount of blood has been lost. The American Association of Blood Banks recommend adhering to a restrictive transfusion strategy in hospitalized stable patients. Transfusion should be given for symptoms of anemia and should not be based on hemoglobin concentration alone. Optimal use should maximize clinical outcomes while avoiding potential risks. Active management in the 3rd stage of labor can decrease the number of women experiencing both severe postpartum hemorrhage greater than 1,000 milliliters of EBL and anemia, defined as a maternal hemoglobin less than 9 grams after delivery. The goal of massive transfusion is rapid restoration that is essential for ensuring adequate tissue perfusion and preventing acidosis, coagulopathy, and hypothermia. Massive transfusion protocols vary considerably from institution to institution, and no internationally accepted protocol exists. The goal of this protocol is to produce an algorithmic, proactive, ratio-based approach to facilitate timely blood product release and mitigate blood bank delays. Please review the specifics for activating massive transfusion protocol in your facility. Regardless of which substance is selected for volume expansion at the start of a hemorrhage, it is essential that blood be administered and that a protocol be available for the issue of blood products. A colloid is defined as a high molecular weight substance that largely remains in the intravascular compartment and creates a pressure. Colloids are considered to have a greater intravascular persistence when compared to crystalloids. The degree of volume expansion is mainly determined by the molecular weight, whereas the intravascular persistence is determined by the elimination of the colloid. When compared to crystalloids, colloids induce a greater plasma volume expansion for the same administered volume. This is an example of a massive transfusion protocol. Early administration of FFP, platelets, packed red blood cells in a ratio of 1 to 1 to 1 before coags prevents early coagulopathy development. Cryoprecipitate is given later in order to elevate the fibrinogen level, since the next step of the protocol is to administer recombinant activated factor VII. At any point if the patient's hemorrhage stops, the blood bank should be notified so that the protocol can be terminated. Once hemostasis is achieved, a maintenance plan policy regarding blood transfusion should be instituted. This slide is a sample massive transfusion algorithm. This presentation has been broken up into 4 main parts. Number 1, preparation and risk assessment. Number 2, recognition. Number 3, treatment. Number 4, communication. And number 5, quality incentives. In summary, this highlights the requirements needed to decrease the risk of hemorrhage in Illinois. Every pregnant patient is required to have a hemorrhage risk assessment throughout her pregnancy. The risk factors in this slide are not inclusive, but highlight some conditions that increase a pregnant woman's risk for hemorrhage. Staff preparation is essential. All staff should know the location of a hemorrhage cart and have a rapid access to hemorrhage medications wherever deliveries occur. The multidisciplinary rapid response team should be assigned roles and responsibilities. Simulation drills help the team prepare for expected and unexpected emergencies. It improves communication skills among team members. Hospitals in Illinois are required to create tools that help facilitate documentation during a hemorrhage, like risk assessment, weighing, EBL as a standard, hypovolemia assessment and documentation tool, rapid response team makeup, trigger and flow, hemorrhage treatment algorithm, product replacement algorithm, activating blood transfusion, including massive transfusion, documentation of the hemorrhage, and quality hospital improvement. The key to management of a hemorrhage is to recognize excessive bleeding before it becomes life-threatening, identify the cause, and initiate appropriate interventions. We have discussed many potentially effective interventions and algorithms. Remember that 2 processes often occur simultaneously: hemorrhage and hypovolemia. Remember, at times blood loss may be concealed or may have occurred prior to admission. It is important to identify signs and symptoms of hypovolemia in addition to using quantification of blood loss. If bleeding from uterine atony is not controlled by uterine artery ligation, we suggest use of a uterine compression suture technique. Early resort to hysterectomy is appropriate in women with severe bleeding due to diffuse placental accreta, increta, percreta, or a large uterine rupture. Hysterectomy is generally a last resort in patients with atony, but should not be delayed in those who have severe coagulopathy and require prompt control of uterine hemorrhage to prevent death. Patients with persistent severe hemorrhage can enter a lethal downward spiral, characterized by hypothermia, coagulopathy, and metabolic acidosis. To abort the cycle, the bleeding area is tightly packed and the wound dressed but left open, and the patient is transferred to an intensive care unit for continuous monitoring, replacement of appropriate blood products, and correction of physiological derangements. Once blood loss is recognized, to stop the hemorrhage and create hemostasis, we remember the following interventions: medications, surgical interventions, using the acronym ORDER to guide our patient management, using O-negative or uncross-matched blood in emergency, or instituting the massive transfusion protocol as appropriate. One quality of an efficient team and team leader is their ability to discuss clinical considerations during high-stake events. These considerations may include treatment protocols, calling for extra help, relieving a coworker who is giving ineffective compressions, having standardized communication techniques for concise communication during crises, seeking ongoing input from RNs and physicians who use the services of the RRT. If there is a severe morbidity, staff may need to talk to crisis counselors. Debriefings are helpful tools that are usually done soon after the event. During that time, individuals discuss what went well and possible learning opportunities. This is a perfect time to make sure everyone is documenting the correct times for events. During this event, it is important to keep the family up to date on the patient's progress. If chaplain services or social work is part of your RRT team, they may be able to facilitate this process. SBAR is a structured format of communication that enhanced the predictability of the information being received as intended and was created by the U.S. Navy. This tool needs to be used with assertion skills to ensure urgent communications are being heard. The sender and the receiver of the communication need to believe they both own the problem under discussion. It requires that communicators be organized in thought and concise in communication. It provides succinct clarity regarding the situation to the provider, who may have to prioritize multiple demands and/or request assistance from another provider. Key steps for reducing maternal mortality and morbidity due to hemorrhage include training of all healthcare providers in early diagnosis, prevention, and treatment options. Promote and reinforce the value and effectiveness of active management in the third stage of labor as standard treatment. Develop and use treatment protocols, and monitor the incidence of hemorrhage and ensure quality assurance. It is a requirement by IDPH that all hemorrhages of 4 units or more and/or ICU admissions be reported to your perinatal center on a monthly basis. It is also recommended to provide a quality review of the critical event when hemorrhages occur. This includes monitoring outcome and process metrics. In an effort to decrease the morbidity and mortality rate in Illinois, IDPH continues to ask hospitals to report hemorrhage morbidities and mortalities to their perinatal center. It is also recommended to debrief with all team members after all hemorrhages, identify the cases where severe morbidity and mortalities can occur, including all cases of hemorrhage greater than or equal to 4 units and/or all ICU admissions. This will help us identify gaps in care that can be discussed at perinatal M&M for quality improvement issues. And finally, to identify whether or not the standard of care was met, not met, or met with room for improvement, so that we can continue to improve the care we provide these patients.